Thank you very much. Last few seconds of the meeting, I'd like to go back to Dr. Shaw and ask her if you had a wish for a screening test to start for the bottom of the pyramid, what would that test be, and how much that would cost?
Well, the goal would be is that you would want a test which was it would be as effective as it could be, but it would be optimally as inexpensive as it could be. Paralleling other test costs, it would be at a minimum. Now, it depends on your perspective, but from a societal perspective, it would be $100 or less.
Less than $100.
In some of the cases, when you think about MR applied to that 40 million people, that would cost prohibitive, in large part because of the amount of induced medications and procedures that could follow that. But certainly I think calcium screening is in that range. We need a lot more data. Some of the laboratory markers are in that range, and that would be a very effective place to start.
Great, thank you. Well, I initially at the beginning of this meeting, I mentioned to you, I gave you a quick report of how many patents are out there on polypill. There were last time when I counted, it was about 130 patents on polypill. Pills that are aggregated to each other. And as the way I see it, there are actually every day, every week, Tuesday, if you get on patent database, you'll see about 30 to 40 new patents released related to atherosclerosis. And I'm amazed to see more than 50% of them are polypill. And this is the wave that I anticipate is happening. And you know, we are scientists in the academia, but the ones who are actually leading and pushing everything is industry, and the money is driving us towards polypill. There is a reason for that, because these drugs, if you accumulate them, the magnitude of effect, Dr. Berman, will be more than 30%. My anticipation, and this has been a lot of brainstorming, that once we start this, now currently you have only statin, and on the very top of the pyramid you have drug-eluting stent. Dr. Saroy showed you how he exercised drug-eluting stent, and his patients were doing very well. And now, you've seen Steve Nissen's data with injection. You've seen new data from Alan Fogelman and Navab, and recently from P.K. Shaw's group that we are having oral HDL therapy, and will give a far greater effect than statin therapy. So that's where we can really see the vision of putting America in shape is based on what we are building. Now, we have two parallel efforts with AHA's leadership and collaboration with others. One is at the CT level. I look forward to getting a chance to updating you while you're presenting about the detectiveness or ability to detect this, and that is to image vulnerable patient, not just vulnerable plaque. And there are a long list. You'll see a few presentations during this city that you can add to the predictive value or diagnostic value of the CT. You have much more information than an average calcium score that you're collecting, and we are not using this information. And if we put them in proper model, we will be able to increase what you're actually doing right now, what you're paying for those data. You take the radiation already. The next level, which Dr. Moreno will be talking about this tomorrow, it's what we call Ultimate IVUS. It's a project, again, with the same nature. With IVUS, you collect so much data. A lot of those data are not being used. Patrick Saroy showed you some of the wavelength analysis, but we, for example, injected microbubbles in the IVUS, and we've seen an enormous enhancement with injection microbubble and vasovasorum imaging. Now, what is vasovasorum? Here's the man who's going to present it the next few days, and Dr. Fuster really inspired everybody in this field that maybe vasovasorum imaging is better than macrophage imaging. The bottom line is we have IVUS already in our hand. How can we empower it? Get more than IVUS. We're paying for it anyway. We have CT in our hand. What can we do to increase the power of CT? The bottom of the pyramid is the mystery, and I've been starting working with PK Shaw and hopefully soon with your group and others, that how can we find a biomarker that would be a risk marker, not a risk factor, because we know that there are so many risk factors that we're not aware of. Now, with proteomics, we might find 50 more. We will find chips that are going to be sold out everywhere, and they do all sort of proteomics. But is that really the way to go? Again, back to analogy of hypertension. I think it's not. We're going to look for the cough test. We're going to have to look for that test that would be less than $100. With that, I'd like to thank everybody that participated in this meeting, and look forward to having the next meeting at AHA, American Heart Association. In between the SHAPE committee, we'll have a small group meeting. We will invite our faculty for a trip to Houston, hopefully at a time that is not too hot, and we will be reporting that as a supplement to Circulation Journal. Thank you very much. If this era rapidly develops,